Our first keynote speaker is Robert David. Robert David was appointed by Governor Edmund G. Brown, Jr. as Director of the Office of Statewide Health Planning and Development on April 13, 2012. He oversees programs responsible for the building and financing of health facility infrastructure, the collection and analysis of healthcare data, and the development and expansion of healthcare professionals to serve and improve the delivery of healthcare, particularly in medically underserved communities. OSHPD employs a staff of 481 people and has an annual budget of $216 million. Robert has extensive experience as a leader in health-related programs and operations in both public and private sectors. Prior to his appointment at OSHPD, I know it's OSHPD, I get that. Mr. David was an executive for the American Hospital Association, where he worked on state and federal issues impacting the industry. From 2005 to 2010, Mr. David served as the Chief Deputy Director for OSHPD, and before that, he was the Regional Vice President at the Hospital Council of Northern and Central California for 6 years. Please join me in welcoming Robert David.
Thanks, everybody. See, that picture was taken when I first started. See, notice the hair? Yeah, that's what happens. It's been a great morning. I've learned a lot about your community. I've made some good contacts, particularly with some of the hospital people, and I hope to be able to help you guys out when you come to Sacramento next to talk about your building projects. My highlight so far for the morning has been finding out from Toby Ewing that there's an extra $75 million available for behavioral health. Boy, I think we're all ready for that. Thanks to Stuart and Linda and the whole West Hills team for putting this together. This is a part of the state that often gets forgotten in Sacramento, that often gets forgotten in San Francisco and in Los Angeles. It's the breadbasket of California. You guys have needs just like the rest of the state does, but oftentimes they don't get addressed. Broadband. I was really surprised to hear the difficulty of getting broadband here. Here we are in 2018. Before I get started, could we take a little minute to be in our thoughts? I just got notice that the Adventist Feather River Hospital in Butte County, there's a fire up there, and they've been evacuated. And the fire is actually very close to the hospital, and so anyway, that's a tough situation. The wind's blowing outside, and I have a friend in St. Helena. The power went out last night. PG&E's doing that now on a preventative basis. So anyway, for those who've not heard of OSHPD, we're the Office of Statewide Health Planning and Development. We're very familiar with the challenges and changes in the healthcare industry. We do 4 basic things in our department. We're California's building department for hospitals and skilled nursing facilities. We perform plan review. We're part of the building code change process, and we enforce California's Hospital Seismic Safety Act. We have very, very high seismic standards for hospitals. We collect financial and patient level data from over 6,000 licensed healthcare facilities, and we perform analyses of those data. And we also help alleviate the maldistribution of the state's healthcare workforce, which we'll get into in a little more detail. And finally, we offer loan insurance for nonprofit and government health facilities, which assist them with financing, construction, and renovations. Workforce, as we know, is the focus of this conference, but before getting into that, I want to briefly touch on the facility and data programs because they're vitally important for increasing access to care and information about care in California. But first, I want to thank all of our partners. We work very closely with state and local advocacy groups, industry members, and many other interested parties because it makes us better and it results in better and more responsive programs, and one of our partners is here today. You'll never have a more knowledgeable health policy expert than Richard Figueroa of the California Endowment, and thank you, Fig, for being here today and for being a supporter of this conference. Well, first, at the most basic level, access to care is dependent on safe facilities. And California is a very seismically active state. Obviously, folks in Coalinga know this firsthand. In the event of a strong earthquake, acute care facilities not only need to be safe, but they need to be able to provide services as quickly as possible after an event. And as we've seen over and over, not just with earthquakes, but also with recent and current fire activity, the importance of hospitals, first and foremost for care, but also as rallying points for communities to recover from natural disasters. I'm happy to report, as we sit here today, that 95% of the acute care facilities in California meet the 2020 seismic standards right now. And this means 95% of these facilities are rated to withstand a strong earthquake. And this is a great achievement by our industry partners, and I thank them. The next step is to bring acute care facilities up to the 2030 standard, where acute care buildings must not only remain standing after an earthquake, but must be capable of continuing operations. It's difficult to move patients, particularly in the ICU and that are critically cared after an earthquake. So ideally, we want to have buildings that can continue operations after a strong earthquake. One theme of the conference is about addressing challenges, and investing more money into facilities is certainly a challenge, particularly for rural hospitals, many of which are struggling financially. And we're doing several things to help with this. Our Cal Mortgage program is insuring $1.7 billion in loans for 80 construction and renovation projects in California, and they have the capacity to do more. OSHPD has promulgated a new standard for the building code called Seismic Performance Category 4D. I was talking to the CEO of Madera Hospital about that, and I think they're going to pursue that, hopefully, and come up and visit with us about it. It's a more cost-efficient option for complying with the state seismic standards. Most of the hospitals that will be benefiting from that are rural hospitals because they're less likely to be in areas of high seismic activity, which makes facilities eligible for this option. Many valley hospitals would be eligible. SBC 4D's helping where removal of older hospital buildings from service could result in communities' loss of the hospital, the closure. We've also taken a number of steps to assist architects and designers to achieve higher safety levels at lower cost, and we've sped up the plan review process because we know that time is money. Another theme of this conference is change. A major change we've seen with respect to facilities statewide is the rise in the number of clinics, particularly in rural areas. Clinics are obviously becoming extremely important for providing access to care. Since the passage of the Affordable Care Act, clinic construction has exploded, as has the need for primary care providers, and not just doctors, but also physician assistants, nurse practitioners, and others. This trend, I certainly see this trend will continue for the foreseeable future as primary care is delivered in a team approach with the physician as team leader, and clinics are really showing the way in this trend. Let me briefly talk about data. OSHPD has a long-standing reputation for being the gold standard in healthcare data, and that's certainly a reputation that precedes me. The legislature has been expanding OSHPD's data role with respect to cost transparency. There's a great deal of interest in cost transparency, both nationally but specifically within California. Implementation of Senate Bill 17, the Drug Cost Transparency Program, is well underway. Since January, pharmaceutical companies are providing 60-day advance notice to registered drug purchasers of price increases above a certain threshold. And early next year, pharma companies will be providing reports to OSHPD on the rationale for those increases. And in the spring, we're going to begin making these data accessible to the public via our website. So cost transparency, this is not, we're not setting prices, we're just saying justify your cost increases, and we're going to let the public know about it. We've also begun, as per the recent 2018 Budget Act, activities to study and then recommend the structure of a healthcare payments database to be administered by our department. The Phase 1 activities, and we're just getting started on this, will result in a set of recommendations and a plan to the legislature by July of 2020. The Senate Bill 17 program and this all-payer claims database are big steps in the direction of greater cost transparency, and although, as I mentioned, it's a national trend, California is definitely leading the way. Okay, let's talk a little bit about workforce. A lot of public discussion has centered on health insurance, which is obviously a very important topic. However, it doesn't do a lot of good if everyone is covered unless there are people to serve them near where they live. OSHPD workforce programs are focused on helping to get the right people to the right areas to respond to community needs. The first step is identifying the areas with the most need, and we have an important role in designating health professional shortage areas. We work with the federal government to identify shortage areas, and we direct state and federal funding, including our own OSHPD workforce programs, to assist in alleviating workforce shortages. Geographically, 43% of the state is recognized as a primary care health professional shortage area, meaning there are too few providers for the population living in those areas. All of West Fresno County is designated as a HIPSA, we call it, for primary care and mental health. So this whole area is a health professional shortage area. This means that local county clinics are eligible to receive a higher level of funding, which helps keep their doors open. A HIPSA designation is a requirement for rural health clinics. We work with clinics and the Department of Public Health to complete their designation as RHCs, and we also provide technical assistance to RHCs for state and federal programs related to the recruitment and retention of their clinicians. Our workforce programs provide financial incentives to encourage underrepresented groups to pursue healthcare careers and individuals and organizations to provide services in those areas of unmet need. These programs are the Song Brown Primary Care Residency Program, Workforce Education and Training for Mental Health Providers, the State Loan Repayment Program, and the National Health Service Corps. In fiscal year 17-18, OSHPD awarded $4.6 million for Fresno County individuals and organizations, including UCSF Fresno with 4 Song Brown Awards, Valley Health Team Clinic, Fresno City College, and Fresno State. Another important issue with respect to access to care is how services are delivered. We have a statutory program where we have the authority to suspend the Business and Professions Code on a temporary basis in order to test, measure, and evaluate new models for delivering care. This is called the Healthcare Workforce Pilot Program, or HWPP. The current program, HWPP 173, Community Paramedicine, is currently active at 17 approved sites in California. Community paramedicine is a new and evolving model of community-based health care. Paramedics function outside of their customary emergency response and transport roles to facilitate more appropriate use of emergency care resources and or enhance access to primary care for medically underserved populations. The statewide project sponsors the California Emergency Medical Services Authority, and one of those sites is here in Fresno County. The Fresno County project sponsors are the Central California EMS Agency and American Ambulance. The Fresno pilot allows appropriately trained field paramedics to perform a pre-hospital medical assessment and transport behavioral health patients that meet established criteria to an appropriate behavioral health facility to avoid unnecessary emergency department transports. This holds promise for patients to be seen in the appropriate setting instead of the emergency room. At the conclusion of these projects, the legislature has the prerogative to decide whether to make these experimental models state law. And this involves a scope of practice change, which can be threatening to some. We just provide the data, so we're neutral. We're neutral. I'd like to conclude by talking a little bit about the Health Professions Education Foundation, which is housed within OSHPD. As far as we know, HPEF, which we call it, is the only 501c3 foundation housed within state government. The foundation offers scholarships to healthcare students and loan repayments to working healthcare professionals in exchange for a service obligation of 1 to 3 years. Awards range from $4,000 all the way up to $105,000. Licensed health professionals are coming out of college or medical school with incredible debt loads. It's really scary, especially for physicians. It's unbelievable. Many would like to practice primary care in underserved communities in the Valley, but feel they need to specialize and work in coastal urban areas for the higher salaries to offset that debt. Loan repayment programs help bridge that gap. Our funding partner, the California Endowment, put together a short video of a health provider who works just down the road in Tulare County. Let's take a look.
When I met my wife, I was madly, absolutely in love with her, but I was a nobody. I had nothing. I didn't have a career. I didn't have a job. I didn't have anything. My name is Alan Valenzuela. I'm a physician assistant. I work in Pixie, California in family medicine, primary care. When I was a student, we were insanely broke. Just trying to handle the studies of medicine and sitting for the tests and getting everything organized, and then to worry on top of that with the tuition. That was very, very hard for us. I was fortunate enough, my program director informed me about Health Education Foundation. I mean, sincerely, if it was not for that scholarship that Health Education Foundation gave me, there was no way I would have graduated. Providing us with the funds to help us finish the school, it gives us that boost to and encourage us to work in the underserved communities and to help those in need. The thing about rural medicine is that a lot of people don't know how rewarding it really is. You get to be involved with the people, you get to be involved with their families, with their relatives. Primary care is very unique because it doesn't just deal with their diseases, it deals with the entire encompassment of these people. On the average, we see about 100 to 120 patients a day. We have a large influx of migrant workers. With Obamacare and this whole opening of a healthcare system, they all get insurances and they all need a doctor. What we tend to find is that we have these small little clinics that are just absolutely bombarded with patients. You go to any rural clinic in the Central Valley, there's not enough doctors here. The people that are running the majority of healthcare in these underserved areas are people like me, our nurse practitioners, our physician assistants. First thing that comes to your mind is, oh my gosh, that's a tremendous amount of studying, that's a tremendous amount of years, that's a lot of work, that's a lot of debt. The beauty about a physician assistant is that our schooling is only 3 years versus a medical doctor that you do it for, 10 to 12 plus years. They train us so well in treating pathology, treating diseases. We have our own medical license. I'm able to prescribe medicines. I'm able to essentially function just like a doctor. There's a lot of patients, they come in with absolutely uncontrolled diabetes. And within a series of 3 to 6 months, their diabetes is controlled. They went from a very high acute risk factor to almost no risk factor, only because I took the time to explain to them in their native language what diabetes really means, why these medicines are important. A family says, oh my God, you're the first that could actually know what I'm saying. So they bring their aunts, their moms, their grandmas. This clinic is growing. I think the most influential thing that got me to go into primary care was seeing this Hispanic gentleman in the trauma room. He came in coded, he had a heart attack. I called the code, a gentleman was brought in, I was doing chest compressions. And for some odd reason, maybe I was just tired, but the whole time I'm doing chest compressions, I'm looking at this gentleman. He reminded me of my dad. And I will never forget this guy's face because it kind of shocked me, it made me realize, man, the answer is not in the emergency room, the answer is preventative medicine. What I'm doing right now, preventing heart attacks, preventing strokes, is essentially what I feel is crucial, because if you could prevent it, people live better lives. Getting this loan repayment, it essentially pays off my interest and a large part of my actual debt itself. It allowed me to take a day off a week, and I get to spend more time with my children. That's just huge, huge. It was a loan repayment that got me to work in this underserved clinic. And it was working in this underserved clinic that made me fall in love with this form of medicine, made me fall in love with the community, with the people I serve. The future of our healthcare is that we're going to need more providers, especially Spanish-speaking providers. If you're looking for a job that is extremely fulfilling, that gives you purpose, that gives you drive, that gives you energy, that gives you excellent pay, I highly advise physician assistant. Any career you go into, it's going to be hard. Medicine's no different. The only difference is that medicine is extremely rewarding. I love my job. And in the meantime, I'm paying off my student loans, which is it's a dream come true.
The Health Professions Education Foundation is a nonprofit within the Office of Statewide Health Planning and Development. To make a donation or apply for a financial incentive award, please visit oshpd.ca.gov/HPEF.
Stories like that's why I love my job. Rural healthcare is always going to have challenges, but if we provide the right incentives, we can open pathways for people who want to serve and make a difference in this valley. We can do it. So let's do it together. And I've got some information on the Health Professions Foundation out on the desk where you got set up today. So thanks for your time. I appreciate it very much.
It's my pleasure to introduce our second keynote speaker for lunch. Ben Hilmes joined Cerner, a leading healthcare technology company, in 1998 and is currently their Senior Vice President of Client Relationships. He oversees Cerner's strategic alignment with Adventist Health, and through a close relationship with Adventist Health leadership, he is focused on driving care transformation, continuous improvement, and delivering value and outcomes for Adventist Health. Prior to his role with Adventist Health, he was the Senior Vice President for Cerner's Eastern region, where he is responsible for all client relationships, business development, implementation, and technology and support services for the eastern half of the United States. Please join me in welcoming Ben Hilmes.
Good afternoon. This is always the inevitable time of trying to present, but now you have dessert on top of that. So maybe I'll catch you on the up. I'll catch you on the up before you hit the down. So, and Bob's sitting here just teasing me. Quickly on a serious note, and I apologize to any of the presenters that were here earlier. I've been back and forth on communications backup with Feather River. So it's a pretty urgent situation. Cerner and Adventist Health formed a relationship back in January. They've been a client for many, many, many years. But in January, Adventist Health outsourced all of their IT and their revenue cycle to Cerner Corporation. So in essence, 10% of their organization is now part of Cerner. And given we were roughly the same size, 10% of Cerner is now Adventist Health. So we've never had a partnership on that scale, certainly from being embedded. In my prior role, I ran the east half of the U.S. for Cerner Corporation on all aspects. And when we formed this partnership, our leadership came to me and said, we have to get this right, and you're moving to California. And so that was quite the ordeal. We moved here 6 months ago, and I can tell you it's been a tremendous time in my short time here in California. But back to Feather River, so we've stood up command centers, we've evacuated the hospital. All the patients are over in Chico, so that is good news. Our Cerner associates who are in an IT building as well as a centralized business office up there have been evacuated. They're all safe, but now it's a pretty aggressive logistics exercise to ensure that we can sustain operations and keep people safe. So if there's more that comes up on that throughout the day, I'll keep you posted. A couple observations before I get into my comments. One was when I was on my way down here, folks asked where I was going, and I told them. They said, well, you might notice that the air is pretty pungent down there. And so when I got out of the car yesterday afternoon, I was actually pleasantly surprised because it smelled like home. I grew up in rural Missouri and near lots of farming communities, and have spent many hours as a youngster in that space. So it felt like home. Secondly, is being here at Harris Ranch. One thing is for sure: if you leave here hungry, it is your own fault. It's unbelievable. The food is fantastic, and And then lastly, and I'll start connecting it to some of my comments, is as I listened to this morning and I had some dialogues last evening, it's pretty clear this room is full of entrepreneurs. And you think about what we're doing is we're being entrepreneurial. And I can tell you that Cerner at its core is an entrepreneurial company spanning nearly 40 years. So I think it's that kind of thinking, and it's the dialogue, but probably the most important thing, which will be later this afternoon, is successful entrepreneurs take risk, they take action, and they're not afraid to be bold. So that's, hopefully we get to there this afternoon in our dialogue, and I look forward to seeing how Cerner Corporation, other private organizations can help and help drive some of those efforts. So with that, I'll begin. Pretty interesting picture. This is circa 1979, and then those three guys on your right, in the center is Neil Patterson. To his right is Cliff Illig, and to the left is a gentleman named Paul Gorp. And those three guys were, in their mid-20s. They kind of look like this table right here. And hopefully, to some extent, I'm speaking to you because hopefully this is inspiring. About three young gentlemen who were working for Anderson Consulting in Kansas City, studying for their CPA exam. Once a week, they'd come together at a park, Luce Park, in Kansas City, Missouri. If you've ever been there, you know where it is. And they'd sit at a park bench, and the intent was to study for their CPA exam. They'd often get distracted. All three of them are extraordinarily entrepreneurial and maybe a bit ADD, but they would start making lists of things that they wanted to do relative to, driven around, we want to start a company. And they'd make these lists. One would be things we know a lot about. The other list would be things we know nothing about. The other one would be things that are easy, and the other side of that would be things that are hard. You can probably guess where healthcare sat on those lists. It was both, one, they knew nothing about it, and two, is really, really hard. And so Neil, the guy in the middle, he's probably the most bold of any man I've ever met. He quit his job at Anderson and said, I'm gonna go find our first gig. And I had no idea what it was. And so they partnered with Marion Labs in Kansas City, and they were hired to evaluate a billing process. But what Neil quickly discovered is the problem wasn't in the billing. It was way upstream in the clinical workflow. And so from there, he and those two guys developed our first solution called PathNet, creative naming, and from there, it's a great entrepreneurial story. So 40 years later, you can kind of see. Don't pay attention to the words, but the graph here. We were a fairly small company. I joined in 1998. We were about 2,000 associates, and in 2012 we hit 10,000 associates. And today we're about 29,000 associates, and about 1,700 of those in California. We're about 13% of our folks are clinicians, and that ranges from physicians to several across the continuum of care, nurses, nurse practitioners, and other technicians across the span. And then if you look in California, our presence here is pretty significant. So we're across the entire state. We'd like to see that grow. We are partners with some of the nameplate organizations in the state and couldn't be more proud to be part of those organizations, helping them deliver great care at high levels of quality. We're about $5 billion in revenue. I say that because it's not that it's about the dollar, but it's about the importance of scale. I think when you create scale, you have your ability to withstand the ups and the downs, and to certainly make decisions that enable you to take big risks. Certainly, as we see where healthcare is going from a volume-based to value-based, and the types of solutions that are going to be needed, and we'll talk about some of those in some future slides. We think having some scale is important. I will say, from a overall wealth generation standpoint, Cerner is a great investment. Just a quick connection. A lot of people don't even know who Cerner is, but a lot of people know who Apple is. And so if you'd had a $10,000 investment in Apple in 1986. Today's dollars, that would be worth somewhere around 1.9 million. That same $10,000 investment in Cerner Corporation would be worth about 2.3. So it's been an incredible story, and one that has created a tremendous amount of wealth for our investors. We work with some of the biggest organizations in the industry, 18 of the top 30 measured by net patient revenue. We are their provider of all of their information systems. And we are global. We have tremendous scale, over 5,000 hospitals across 35 different countries. And you can read the numbers there, but certainly have pervasive engagement across the globe. We've been recognized as one of the most innovative companies in the world, and that innovation comes a lot from the attitude and the culture that was established in 1979 by our founders. But we invest heavily in research and development. We'll do about 750 to 800 million on an annual basis just in research and development, and our engineering organization is roughly about 6,500 people based in Kansas City and throughout the world. And then we've been recognized as one of the most admired companies in healthcare. And so I say all that because I want to see us be more engaged in dialogues like this, because one thing I see missing from a lot of the dialogues, and I think about some of the boards and some of the groups that come together, is there isn't representation from organizations like ours or others. And I think there's some of that thinking that could be embedded in some of those groups to provide a different perspective, some innovative ideas, or connect some dots based on our experiences and the interactions that we have throughout the industry. So somebody said earlier about meeting people where they are. So with the Affordable Care Act, healthcare became digitized. And if you look at other industries, and when they become digitized, really, really cool things happen. So you think about the first 30 years of our existence, we basically were putting in plumbing. Healthcare has been digitized now. That fundamentally changes the game for how we can think about what do we do to go create value and engage on a whole different level, and the skill sets that are needed to address some of these rising concerns. And the exciting thing is since we are digitized, we now have a new platform in which we can go develop and create innovative solutions. Some of these things have been said this morning, so I don't want to repeat them, but I mean, we have some significant challenges, right? Over $10,000 per capita in the U.S. on spend. We have 10,000 people a day in this country that are reaching the age 65. And then overall spend is going up, yet the workforce that is there to support them is decreasing. So these are graphs, you can take them, but one of the pictures that I've come across that I think is pretty compelling, so let this sink in. It's pretty sobering to think about the evolution of where we're going. I mean, it's as if this table here in the future, you're going to be holding up this entire room. And that's a huge responsibility, and I thank you for it. But I think the challenge is for how do we go change this? How do we start, seeing this go the other way? And I think that's on all of us to think through. To get down to more of an individual level, even though we've had tremendous advancements in regulations, et cetera, we are still faced, 28 million lives uncovered. 12% of the population just lack access to just the basics around access to health care. And in the meantime, we're seeing premiums go up at 105% there. And then we're starting to see a tremendous rise in the high deductible health plans, which those that work inside of the provider organizations are also seeing that translate to higher bad debt, higher levels of charity care, et cetera, and it's becoming an unsustainable model. And then over on the provider side, we've seen 30 hospitals a year close since 1975. We are seeing, and you've heard about them already, workforce shortages across the board. And then one that we take very seriously and spend a lot of time trying to figure out how do we help, because if you do the surveys with physicians, at least on the top 2 or 3, reasons why they feel burnt out is their interaction with their electronic medical record or with technology. And that's not just, this is a physician stat, but that's not just physicians. That's nurses, that's nurse practitioners, that's physician assistants across the board. That burden is on us to work with you to figure out how do we make solutions that are easy to use, that are aligned in your workflow, that are contextual, that eliminate kind of the burden of interacting with technology in a very inefficient and ineffective and low quality manner. And then we've been talking about behavioral health. So 1 in 5 physicians have been clinically diagnosed as being depressed. So and then if you look at Cerner Corporation, so we're self-insured, so we have all the data, and our number one diagnosis through our health plan is a behavioral health or mental health issue. So it's real. It's not just across this group. It's across us, and it's across the communities that we serve. So switching to kind of where we think we're going from an innovation platform, like I said, we've digitized the industry. So at the base of that is an EMR, so the electronic health record. But where we're going is certainly how do you leverage those platforms, and you're starting to see the demand for innovation at such a pace that we've transformed, or in the process of transforming, not from an ER company, but to a platform company. We believe we need to open our systems up to allow for innovation to happen on top of our platforms. And the analogy I would use there is think of us as becoming the iTunes for healthcare. So opening up to young entrepreneurs who are willing to be aggressive and think boldly about how do I develop applications that can sit on top of your platforms that can deliver next generation types of solutions and services to address some of the growing challenges. So we're seeing progressive movement in the technology space to systems that are smarter, that are more contextually aware, leveraging things like AI, machine learning, et cetera, to start to diagnose things that the humans can't possibly put together. One of the things I'm very proud of Cerner for doing is we've built some very sophisticated algorithms that run on top multiple sets of data, not just Cerner's EMR, that bring things together to diagnose things like sepsis. So we put an algorithm out there that has now saved more than 350,000 lives across the country. And it's things like that. That's one idea of many, many, many that we know systems can do. We have to create the linkages, and we have to open up these systems to talk to one another so that we can do some of these more sophisticated algorithms and work to save lives. And then beyond, at some point, healthcare, to some extent, from a technology perspective, and I don't have my phone on me, but I mean, the reality is it should just follow you. Everywhere you go, everywhere you are, healthcare, your provider, your wellness care, et cetera, is just part of your daily life. So that's kind of getting to the continuous health thought. And given that there's tremendous amount of opportunity from an innovation standpoint, we're seeing the investment community follow. So this year, more than $11 billion will be introduced into different types of investment opportunities from the VC companies, and you can kind of see where they're focused: patient and consumer, population health, personalized health. They're making big bets that they have an opportunity here to go create tremendous change inside of some of these innovative platforms. And then lastly, this connects really to, I think, the topics of today, which is where's healthcare going from a technology perspective. And I can tell you in each of these areas, there are shortages in talent and skill sets that need to be developed. And so thinking about mobile health, thinking about data management, the analytics that are needed, robotics are playing a large role, contextually aware solutions in the development of those. And then cybersecurity, it is probably one of the biggest risks that we have. We are very fortunate this past couple years. We have earned the opportunity and a huge responsibility to provide our solutions across the DoD and the VA. And while that's a tremendous honor, it's a tremendous responsibility. And I can't tell you how rigorous they have been on us relative to security. And I think it's going to elevate not just our work with them, but our work with all of our clients as we kind of raise the bar relative to security. So I'm going to land there with this. Neil was a awesome guy. I got to work with him a lot. And we lost Neil in July of last year, but gosh, I'm sorry. Anyway, he said, live good lives, be bold, be brave. And I kind of laugh. He says, don't be a wimp. That was just kind of his mentality. And I think that's the mentality of this group, right? You guys are bold, you're brave, and I don't see any wimps here. So let's go get some good things done, because I like you, healthcare is personal, and it's certainly too important to stay the same. So thank you.